Hey, BC here for BC Nephro. Thanks for watching. Today I'm going to talk about dialysis and acute kidney injury. Specifically, what are the indications? When should we start dialysis in patients with acute kidney injury? Now, the standard indications for initiation of dialysis are the following: uremia, life-threatening hyperkalemia, metabolic acidosis, or pulmonary edema, all refractory to medical treatment. Another indication would be life-threatening intoxication with a dialyzable drug. Now, in these patients, you may need to do dialysis regardless of the presence of acute kidney injury or not. But in a patient with decreased kidney function, you would be more likely to dialyze these patients, as there would be decreased renal elimination of the toxic drug. This leaves many questions and that needs some clarity about practically when do we start dialysis. So the questions are the following: what is uremia? What is life-threatening hyperkalemia, metabolic acidosis, or pulmonary edema? What about patients with oliguria or anuria? And is there a benefit to dialyzing patients sooner? Is there improved prognosis if we initiate dialysis sooner as opposed to waiting for one of these indications to develop? Fortunately, there are several studies that provide some guidance and clarity practically for us, and I will add some of my experiences, some of my personal opinions as well. Now, for more information on these studies, check out the article at bcnephro.com. A link will be in the description below, and the article will have links to the 4 studies that I will be referring to. Let's get into it. These 4 studies all looked at patients with either stage 2 or stage 3 acute kidney injury who were critically ill in the ICU setting. So we're talking about ICU patients whose creatinine either doubled or tripled and who had oliguria for at least 12, if not 24 hours, or anuria for at least 12 hours. So we're talking about the level of oliguria practically is essentially less than 500 cc's in most patients for either 12 to 24 hours, or anuria for 12 hours. First of all, what is uremia? Uremic symptoms that convince me there's a need to start urgent dialysis are, first of all, a pericardial friction rub, and second of all, CNS manifestations, which I see as either myoclonus that's not explained by a medication such as gabapentin, or seizures that is not explained by a seizure disorder. Some of the other manifestations are too nonspecific. Some of the things like nausea, mental status changes, and bleeding, these things are too nonspecific to be used by themselves for me to convince me of a need to start dialysis. 2 of the studies look at BUN levels. Now, BUN level technically is azotemia and the clinical symptoms are uremia, but there can be some guidance about certain BUN levels. These BUN levels are in patients who have acute kidney injury, not BUN levels by themselves, but in patients with acute kidney injury, the first study randomized patients to initiating dialysis straight away as soon as they had acute kidney injury, or waiting till one of the complications for a certain period of time developed, and one of the complications was a BUN level of greater than 112. And they found that there was not an improvement in mortality. A number of the patients who you did wait ended up not needing dialysis because they recovered, and there was actually less complications in the patients who delayed. Then the same study investigators took those patients who made it to the BUN of 112 and either started dialysis straight away or waited to the BUN hit 140. Now, they found that there was a trend toward increased mortality in the patients who they waited to the BUN of 140. So if we're talking about patients with BUN cutoff and patients with acute kidney injury, somewhere in between 112 and 140 is where we should be thinking about starting dialysis. Second, what about these other life-threatening complications? So these studies used potassium cutoffs of 6 to 6.5 that they decided that was an indication to start dialysis. These studies used a pH cutoff of either 7.15 or 7.20 with either a depressed PCO2, an inability to ventilate, or a bicarbonate less than 12. So that gives us the guidance there. And then there were certain cutoffs for pulmonary edema that was life-threatening, and essentially they used certain FiO2s or PaO2 to FiO2 ratio, but essentially it was requiring more than 50% FiO2 practically. So these would be the best evidence we have as indications for these three things: hyperkalemia, metabolic acidosis, and pulmonary edema. If you can't control them medically, then starting dialysis. Now, what about oliguria or anuria? The studies show that this is not an indication for emergent initiation of dialysis. My take on it is this: if you have oliguria or anuria for long enough, you will develop one of these life-threatening indications because your body will not be able to get rid of fluid or potassium. If you have it long enough, you will get hyperkalemia or pulmonary edema. But this study essentially looked at patients who were oliguric, starting dialysis straight away, or waiting 72 hours. And essentially the patients did not do better from a mortality wise. So oliguria without another life-threatening indication, the best evidence we have is we can wait up to 72 hours before starting dialysis and monitoring them closely. Some of the studies also looked at waiting for 48 to 72 hours and started dialysis only if the acute kidney injury did not improve or resolve in a 48 to 72 hour period. There's no benefit to starting dialysis sooner. So this is the best evidence that we have. You can observe closely for 48 to 72 hours and initiate dialysis either if one of these indications develop or after the 48 to 72 hour period. What you'll find is these patients, there is not a worsening mortality. There may be a decrease in complications, and a certain percentage of these patients will end up not needing dialysis. So that's it, what the studies show and my opinions about initiation of dialysis in acute kidney injury. If you made it this far, thanks for watching. Hit the like button, subscribe, let your friends know, and until next time.